Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the June 2024 issue of the journal Chest. We have a great lineup of content in this month's issue. Over the next 15 minutes or so, I'll provide a brief overview of key manuscripts published in each of our content areas. First will be our asthma content area. The assessment of response to treatment in allergic bronchopulmonary aspergillosis is a major challenge. In this issue, Godet and colleagues report findings from an ancillary study of a randomized clinical trial that included 139 patients who were being treated with corticosteroids and itraconazole for exacerbations of allergic bronchopulmonary aspergillosis. The study was designed to determine the most relevant changes in CT scan parameters for assessing the response to treatment. 5 CT parameters showed significant changes at the end of treatment: mucoid impaction extent, mucoid impaction density, centrilobular micronodules, consolidation and ground glass opacities, and bronchial wall thickening. There was only a weak association between these factors and no agreement between clinical, immunologic, and radiologic response. These findings identify relevant CT scan parameters to assess radiologic response to treatment of allergic bronchopulmonary aspergillosis, while suggesting a multidimensional approach to assess a composite definition of response to treatment outcomes. Next is our chest infections content area. It is unclear whether patients with rheumatoid arthritis have a higher risk of bronchiectasis, and whether seropositivity for rheumatoid factor is associated with an increased risk of bronchiectasis. In this issue, Choi and colleagues report findings from an evaluation of over 50,000 people with seropositive rheumatoid arthritis and nearly 36,000 with seronegative rheumatoid arthritis, as well as a 1-to-5 cohort matched by age and sex from the Korean National Health Insurance Service database, designed to determine whether rheumatoid arthritis and rheumatoid arthritis seropositivity are associated with the development of bronchiectasis. The cumulative incidence of bronchiectasis in those with rheumatoid arthritis was 7%. People with rheumatoid arthritis had a 2.1-fold higher risk of developing bronchiectasis, 2.3-fold in those who were seropositive, and 1.6-fold in those who were seronegative. These findings identify and quantify the association between rheumatoid arthritis seropositivity, and bronchiectasis. Also in this section is an original research study that investigated the characteristics and prognosis of PJP pneumonia according to underlying disease, a time series analysis of the impact of SARS-CoV-2 vaccine rollout on Hispanic and non-Hispanic admission and mortality trends, and a population study of the burden of pertussis among adolescents and adults with asthma or COPD in the United States. On to our COPD content area. Interstitial lung diseases have been reported as pulmonary manifestations of rheumatoid arthritis. In this issue, Chung and colleagues used the Korean National Health Insurance database to identify over 46,000 patients with rheumatoid arthritis and over 230,000 matched control individuals to determine whether those with rheumatoid arthritis have an increased risk of developing COPD, and whether that risk is influenced by seropositivity for rheumatoid factor. Patients with rheumatoid arthritis had an adjusted hazard ratio of 2.1 for developing COPD, 2.2 in those who were seropositive, and 1.8 in those who were seronegative. Smoking history did not demonstrate significant interactions between rheumatoid arthritis and COPD development. These findings associate rheumatoid arthritis with an increased risk of COPD, which is augmented by seropositivity. Completing this section is a How I Do It review about home non-invasive ventilation in COPD. Next is our critical care content area. The physiologic mechanisms impacting a reduction in intubation rates from reconnection to the ventilator for 1 hour after a successful spontaneous breathing trial are unclear. In this issue, Kudroy and colleagues describe an ancillary study of a randomized clinical trial that compared spontaneous breathing trials performed with a T-piece or with pressure support ventilation, designed to determine whether reconnection to the ventilator for 1 hour reverses alveolar de-recruitment induced by a spontaneous breathing trial. In the 25 patients included, the end expiratory lung volume decreased by 30% after the spontaneous breathing trial compared with baseline. The reduction was greater after T-piece than with pressure support ventilation, 43% versus 20%. After reconnection to the ventilator for 1 hour, the end expiratory lung volume increased to 96% of the baseline value. Recovery occurred within 10 minutes for those assigned to pressure support ventilation, but not to T-piece. These findings identify significant alveolar de-recruitment at the end of a spontaneous breathing trial, which was more pronounced with a T-piece and fully recovered within 1 hour of reconnection to the ventilator. Other original research published in this section includes a post hoc analysis of a randomized trial assessing the association between malnutrition and high-protein treatment on outcomes in critically ill patients, a randomized crossover trial of high versus low PEEP in ARDS patients exhibiting intense inspiratory effort during assisted ventilation, and an assessment of concordance of microbiome profiling of endotracheal tube aspirates with direct lower airway sampling in intubated patients. A research letter reports on lung consolidation depth and gas exchange in different types of neonatal respiratory failure. A special features article proposes hospital onset sepsis as a unique clinical entity requiring expanded investigation, and a point-counterpoint debate on the need to maintain direct laryngoscopy as an essential skill completes this section. On to our diffuse lung disease content area. The impact of immunosuppression for treatment of fibrotic hypersensitivity pneumonitis across different types of antigen exposure has not been studied. In this issue, Mullen and colleagues identified 344 patients with fibrotic hypersensitivity pneumonitis from the Canadian Registry for Pulmonary Fibrosis and evaluated whether disease outcomes in response to treatment varied by antigen type, including avian, mold, other, and unknown categories. Approximately 58% of patients across antigen types were treated with immunosuppression. Lung function and symptom scores did not change with immunosuppression across the full cohort. Immunosuppression was not associated with survival for those with avian or mold antigen exposures, though the confidence intervals were quite wide. Patients with unknown causative antigens had a worse survival when treated with immunosuppression, with a hazard ratio of 2.65. These findings suggest the response to immunosuppression may vary by antigen type in patients with fibrotic hypersensitivity pneumonitis, with further study required to determine the role of treatment. Completing this section is a research letter exploring the association between sarcoidosis and hematologic comorbidities. On to our education and clinical practice content area. The learning environment of ICU rounds, where multidisciplinary providers integrate complex decision-making and teaching in a noisy, high-stress environment, includes many cognitive distractions. In this issue, Held and colleagues performed an observational, multi-site study of multidisciplinary providers during ICU rounds, designed to determine what features of ICU rounds correlate with high provider cognitive load. 76 providers were observed during 32 rounds, with a mean rounding time of 2 hours and 17 minutes. The mean extraneous load was 20.5 events per hour, which included 8.6 distractions, 8.2 communication deviations, 1.9 repetitions, and 1.8 episodes of split attention. Increased cognitive load, assessed using the Provider Task Load Instrument, was associated with hourly extraneous load events, number of new patients, and number of higher acuity patients. These findings may help to modify ICU rounding structure to optimize provider learning and performance. Also in this section is a special features article that describes major principles and new realities when preparing for fellowship in pulmonary and/or critical care medicine, and a How I Do It review on the application of non-invasive ventilation in the treatment of acute exacerbations of COPD. Our pulmonary vascular content area is next. Little is known about health-related quality of life in forms of pulmonary hypertension other than pulmonary arterial hypertension. In this issue, Balasubramanian and colleagues report findings from a cross-sectional study of 691 patients from the pulmonary vascular disease phenomics cohort study, designed to determine if health-related quality of life varies across groups of the World Symposium on Pulmonary Hypertension Classification System. Health-related quality of life was severely depressed across all pH categories. It was found to correlate with functional class and 6-minute walk distance, but not hemodynamics. Compared with Group 1 subjects, Group 2 and 3 subjects had significantly worse health-related quality of life despite less severe hemodynamics. These findings highlight the impact of pulmonary hypertension on health-related quality of life for non-Group 1 pulmonary hypertension and the poor correlation between hemodynamics and health-related quality of life. Also in this section is an original research article that evaluated the role of left ventricular dysfunction in systemic sclerosis-related pulmonary hypertension, and a chest narrative review of methamphetamine-associated pulmonary arterial hypertension. In our sleep medicine content area this month, you will find a research letter that evaluates the effects of negative pressure ventilation on lung volume and airflow in drug-induced sleep endoscopy. Next is our thoracic oncology content area. There has been variable definitions of diagnostic yield and accuracy in studies evaluating advanced diagnostic bronchoscopy devices. In this issue, Leonard and colleagues applied commonly used definitions of diagnostic yield to a prospective dataset of 450 biopsy specimens from consecutive peripheral pulmonary lesions sampled through navigation bronchoscopy to determine if a conservative diagnostic yield definition, defined as including malignancy or specific benign findings as diagnostic, whether that conservative diagnostic yield definition results in few false negative initial results closely approximating diagnostic accuracy. The prevalence of malignancy was 60.9%. Initial bronchoscopy pathology yielded malignant diagnoses in 50.4% of patients, with 0.4% being false positive over 2 years of follow-up. Biopsies with specific benign findings had a 1.9% false negative rate, while those with non-specific benign biopsies had a 38.7% false negative rate, again over 2 years of follow-up. There was a 0.7% discrepancy between diagnostic yield and accuracy for the conservative definition. These findings suggest a conservative definition of diagnostic yield can closely approximate diagnostic accuracy through 2 years of follow-up, allowing reliable diagnostic utility data without protracted delays. Completing this section is an original research article that evaluated risk-adapted starting age of personalized lung cancer screening in China. I encourage you to read our Humanities and Chest Medicine section, where you'll find an original research article that evaluated implicit bias in intensive care unit notes with a word-embedding neural network model, and an exhalations piece titled A Winter Path. And our commentary series, where you will find an update on the National Cancer Institute's smoking cessation at lung examination collaboration trials. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope you enjoy reading all of the content available in this month's issue of Chest. As always, I'm grateful to the authors of this work, the reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope you enjoy the June issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.